Good morning, everyone. It's really wonderful to see you all here. My name is Janet Farmer. I'm the Director of Academic Programs at the Thompson Center for Autism and Neurodevelopmental Disorders at the University of Missouri. And I would like to start by thanking the people in the room who have made this meeting possible, but also the people who have actually made the autism legislation itself possible. We still, you'll hear some mixed messages today in terms of successes and challenges that we've had, but we still believe that this ultimately is going to make a substantial difference for kids and families. So, having said that, the goals of our talk, we have, would you mind advancing? Yeah. We have two goals of the talk. One is to tell you about our journey. Catherine has already started to tell you about some of that. You could tell that we are very fortunate to have a team of people. And I know not everybody is in that position, but we're hoping that even if you're not, there'll still be things that we share that you can benefit from. So we're going to talk about that. And then we'd like to open it up to your comments. This has been a wonderfully interactive group. And so we just want to encourage that. This slide is just intended to tell you that the Thompson Center has somewhere between 15, 16 clinics. We have medical clinics that have been billing health insurance for years. We have psychologists, one of whom is here, Dr. Melissa Armstrong, billing health insurance for many years. So we have a track record. But as you could tell from Catherine's comments, this has been very different for us to get into billing for ABA services. So there's you can't read these, I apologize, but there's medical services, there's health professions, which are psychology, speech language pathology, occupational therapy. There's the intervention services. That's where our behavioral experts are, and that's where we're going to focus today. And then we have care coordination in the Thompson Center to help families access services across the state. We do see kids from all but 4 counties of the state at the Thompson Center, so sometimes that's a challenge as well in terms of understanding these systems. Okay, now I'm going to turn this over to the people who really are in the trenches doing this work. So let me introduce to you Dr. Jamie Severtson, who is a co-director of our Intervention Services Division. I'd like to mention that Dr. Jessa Love was also able to come today, and she is the other co-director of the Intervention Services Division. Thank you.
Hello. I think a lot of the questions that some folks had earlier are some things that we might be able to address, and then you still might have questions that we won't be able to address, but we'll do the best that we can. Needless to say, getting credentialed with insurance companies has been a challenge, and some of it has just been time-consuming and just getting all the details in order. I am really excited to say that the licensure part was the easiest part. Yeah. Also, a little bit of other information. Before I came to Missouri, I worked in the state of Illinois, and we had a similar mandate. But I just want to say that Missouri is light years ahead in terms of like how fast you were able to actually get this going, get a board together. And the fact that this mandate passed in January and that we're able to bill now, even though it's not, on a very small scale, we're still billing. And so that's really exciting. And that we have this behavior analyst board and this licensing board is really exciting. So in terms of licensure, you have to have your national certification. And then you have to follow the instructions on the website to get a license. And if you follow the instructions on the website and pay your $150 and you pass all the background checks, you're going to get a license in a couple of weeks. And it was so fast. So that part was really simple. If you have specific questions about that, if there are behavior analysts in the audience that have specific questions about that, feel free to get a hold of me. But really, the instructions on the website are great. Credentialing, we worked a lot with university physicians. Dana, did you want to speak about CAQH at all?
somebody going to be talking about that later when there's discussion about credentialing? Don't you have somebody talking later about credentialing? Are you going to be talking about the CAQH website? All right, I'll just mention it. So one of the things that we learned is that there is a universal provider data source through CAQH, and when the payers come up here, they may be able to talk whether they recognize this through their insurer or not. But you can go to this website and learn more. It's free, and its purpose is to give providers a free source for entering all the information that most payers are interested in. And then, of course, it varies, I suspect, which payers accept this information in the process of credentialing, whether they need additional information. But it does give us hope that perhaps eventually there'll be one form to complete that payers would accept for credentialing purposes. That's all we wanted to say, is to call your attention to this.
Not every health plan and not every provider has to use this. It's not required at this time. But if you go to their website, there's like 12 pages listing what different agencies and different health plans actually use the CAQH website. I can pass this around if you want to take a look, but it's all on their website. You just hand that there. If you'd like, but it really is all on their website. Okay. I think it's like 13 pages. Okay, there you go. So I was on the provider end of the credentialing process, so let me just speak about that a little bit. All of the forms that we had to complete, although university physicians really tried to limit the number of forms that we had to complete, we still had to complete a number of forms. And I think as we go, the number of forms that we have to complete is going to be shorter and shorter and shorter. But one concern that we had was the language was really specific to medical providers. And so you want to make sure that when you're completing these forms that you know what you're filling out. And we were fortunate enough to work with, again, UP to have all of our questions answered. And I think, you might have to work with a billing agency or find another person who's familiar with filling out these forms so that you know what you're filling out and that you're checking all the right boxes. For example, almost all the time the clinician was referred to as a physician. I'm not a medical physician, and so that was a little bit confusing. I think as this rolls out a little bit more, forms will be created specifically for behavior analysts, so it'll say behavior analysts. We're just not there yet, so don't let that scare you. Just make sure that you understand the forms that you're filling out. Let's see. We talked about that. Oh, and once you're a licensed behavior analyst in the state, and let's say you have all of your forms filled out, as a provider, you should plan on about 3 to 6 months lag time for each different insurance company. UP kept track of all of that and made sure that we had all of our forms filled out. If there was anything that was missing, they kept track of that. But if you're counting on billing insurance companies as part of your revenue, there's going to be some lag time there. So be prepared for that. And especially if you're hiring new people. So when we were in the middle of this, we hired some new behavior analysts, and one of them was from out of state. And so we couldn't do the credentialing process right away, but we could go ahead and get her started on filling out the forms for licensure, so that way when she started, we could hurry up and get her credentialed and get her billing right away. And then she started seeing some other non-insurance clients first, so that way, the revenue was flowing. Billing procedures. Monica, did you have anything that you wanted to add on that part? Brenda?
No, I think on the slide it says contracting with a billing agent.
Oh,
And I think that had to do, are you talking on that?
I think I have some notes.
Good. So, no.
Okay. For our billing procedures, again, I have a little bit of experience with this from when I worked in Illinois, but again, working with UP has been so helpful. So it's, yes. University physicians, sorry. Sorry about that. If I say UP, that means University Physicians. So in order...
Could I add one more thing? So Catherine represents University Physicians. She talked earlier. It's the University Health System's billing agent. Yes. Yes.
So not every provider is going to have the luxury of being able to work with an agency like UP, but there are other billing agents out there. I'm not familiar with them, so I won't be able to answer that question for you. But there are some things that when you're looking for a billing agent to work with that you're going to want to consider. First of all, you want somebody who knows what they're doing. Do they know about billing for ABA? ABA services, behavior analysts do not have their own codes right now. We have these other codes that we're able to use that are also used by other providers. And so if you're working with a billing agent that doesn't know about ABA and doesn't know about what codes to use, you could get in some trouble down the road if they're trying to help you bill. You might have some unsuccessful billings there. You want somebody who's really going to help you with this credentialing process, because it's a little bit confusing right now. Hopefully that'll get easier later, but you want somebody that's going to help you do that. If they're not going to help you with the credentialing process, you might want to look somewhere else, because that part is so crucial and so time consuming. You also want to make sure that you're working with somebody who takes your business seriously, even if you're dealing with a really low volume of clients. Jess and I were just talking that to date, I think we've only billed insurance companies for about 23, thank you, 23 clients. So in the grand scheme of things, that's a pretty small number, but you want somebody who's going to take that seriously. And people who are available to answer your questions, because we had so many when we were getting started. And then I think we'll talk about this a little bit more a little later, but some folks who are going to provide you with lots of data in terms of monitoring your collections. How many denials have you had and why? And I've got a lot more information on that for another slide, but just some things to think about. It's not just will they submit your billing, but will they provide all of these other services for you as well? Because if they don't, you're going to have to figure that out on your own as a provider. Sure. So in your packet, we have an encounter form. Thank you. So it's going to look something like this. Okay. So this was something that University Physicians put together. Is that right, Catherine? And so it really was meant to be both an internal and external document. And so we took the most frequently used codes and put those on there. You'll see that we have the different provider types across the top. But anyway, it's just one example of a really simple form that you'll want to design for your own providers. Because this form, I have to do so many things as a provider. I don't want a form that's going to be very time consuming. So this was extremely helpful. So I circle something, I check some boxes, and it's pretty easy to fill out. And if I miss something, it's simple enough that Monica, who helps us keep everything going, will say, hey, Jamie, you forgot to check this box, or you forgot to fill in your number of units. And even if I fill all of this out correctly, because different companies use different codes, when this goes to University Physicians, they still have to translate. So if I check an H2012 box, that might be the right code for one company and not for another, and UP will make sure that that gets straightened out before they submit the claim. Okay. We've talked a lot about codes already. And so I'm not going to go into that. You already have a handout about specific codes. Are there any questions so far? Mm-hmm. How do you find a billing agent? I don't know. How do you find a billing agent? Nobody knows. Okay.
help you identify some billing agencies. I have lots of contact information at the end if you have any questions. But yeah, and you simply can just look up different billing agencies for that local online.
Thank you.
I have a question.
Yes.
On your form, under procedures, on the top one, why are you breaking down your H2012 direct radiation? Why are you breaking that down into 15 minutes since that's a 1 hour?
It's a 1 hour code for most plans. For some plans, it might be 15 minutes.
I think the idea was to go to the lowest common denominator, and then we could roll up specific to each payer's requirement.
So again, if we're filling this out for one client visit, and I put 4 because I say 4 15-minute units. When I send that over, somebody from Catherine's team is going to know, hey, for this company, that really should be a 1. So yeah, it's not simple. Some other notes about billing forms and processes. Someone else already mentioned earlier that we had to go through a pretty significant audit process for one payer before we could do any billing. So although this was a tedious process, it was very helpful because the audit forced us to review our policies and procedures, and we had to create or edit existing procedures as needed. So for example, from that audit process, we developed a form, or we updated templates. So to make things as simple as possible and save time for our clinicians, we updated all of our evaluation and exit report updates. We created progress reports so that way if an insurance company requires certain information every 6 months, we're prepared for that, and it takes our provider very little time to fill out that report. We have a template for all of our clinical notes and all of the requirements for this particular payer. What's great is that this particular payer, the audit was really specific to services for applied behavior analysis services. And so if we followed those instructions, it seemed like all of the other payers asked for very similar details. So we went through this once. It took a lot of time. We set up a lot of infrastructure, and it made it much easier for us. And we're still tweaking things as we go. But other things that we had to revise, our intake process, we had to clearly define what our intake process was. How do we transfer clients from one provider to another, even within our own agency? We had to clearly define our discharge process and also the paperwork requirements for our clinicians. And from that, we also created a new internal audit system to ensure that providers are completing their necessary paperwork and that all of our client files were up to date. Now, we're fortunate that at the same time, we got to start using the electronic medical record, which is helpful, but because we weren't using that before, there were still some details for different clients that were missing, and we had to go back and make sure that we had, for example, documentation of a diagnostic evaluation and that sort of thing, so that it was all on file in case it was ever requested of us. Let's see. Just making sure I cover. So I mentioned that we made these evaluation or we made these templates for our reports, and you have to submit a report to the insurance company, let's say following an assessment. Not for every company, but for a lot of companies, you submit this evaluation report after your assessment so that you can get approval for treatment. And so one of the things that we found that was really helpful was highlighting the information in the report that they need to see. So each payer has a form usually that says what they need you to tell them about your assessment before they'll approve treatment. So it might be that you have to tell them about what your data collection system is going to be, or defining the target behavior. Well, rather than take what's in your report and fill out that form again, we highlight what's in the report and make sure that they understand this is, and we write in that form, see the report or something like that. So then the clinician doesn't have to do double work, and neither does Monica.
I'm going to tell you a little bit about the process that I go through for the intake and authorization process. First, during the intake process, I get the member ID's number, the name of the insurance company, the member ID, subscriber's name, subscriber's date of birth, and then it's also helpful to find out if their insurance plan is through their employer. That helps determine the type of plan, because like some, for example, the City of Columbia, specific plan with a certain payer may not cover autism when that plan usually covers it. I request a front and back copy of the insurance card so that I have all the information in front of me when I call the insurance company. I will not call the insurance company unless I have this, because it will make it a much easier process so that I'm getting all the correct information to the insurance company. I also request, make sure I have a copy of a report with the child's diagnosis of autism, because we're required to have that on file, and then the insurance company is going to request that in order to authorize services. When I call the insurance company, generally you get an automated system, and it'll take you through the process where you can get to where they'll give you the client's benefits. So you can get an idea of what their copay is or what their deductible is going to be. And then the insurance company, once I get a representative on the phone, they generally ask me the ID on the insurance card, the child's name, child's date of birth, tax ID, the provider, sometimes their credentials of who's giving the service, sometimes the provider's MPI number, and I think that's about it. I specifically ask if the client has coverage for autism ABA therapy. The insurance representative may ask me for billing codes, and then I can give them, because we already have set rates and billing codes, I'm able to tell them what codes that we are contracted with. I also ask if authorization is required. Some insurance companies require authorization for both assessment and treatment. Other insurance companies may not require authorization for assessment, but then you'll have to send your report in afterwards to get authorization for treatment. And then there's other insurance companies that do not require authorization for either. And then, like it was mentioned earlier, if I'm having difficulty understanding with the insurance company whether a client is covered or not, I will request an autism specialist. But the autism specialist, not all insurance companies have an autism specialist. So at that point, I contact Brenda to see if she can help me find a contact. Once I know that there's authorization, usually the insurance will require a diagnostic report, a script for ABA therapy from an MD or PhD. And with a particular payer, they require that we have a release of information on file. And then anything else, it can vary by, like she was telling about our audits, there might be other forms that are required that we have on file, but the insurance company doesn't require us to send those in.
So that kind of covers the family documentation, and that part can be a little bit overwhelming for the families to make sure that they're getting everything in. And so Monica, her key role is really helping the families get all of that information in and really understand what they need to complete and what all of those forms mean. So we appreciate her greatly, and she keeps us in line. For clinical input, so again, this is usually after I've completed an assessment, and I am submitting a report to an insurance company in order to get treatment plan, or treatment authorized. This should be a no-brainer for behavior analysts, but you have to write measurable goals. And that has to be included in your evaluation report. And you have to be able to explain how you're going to take data and how you're going to monitor the child's progress over time. They're going to want to know that. And you should be doing that already, so this should be easy. Something that was a little bit different was that the parents have to sign off on your report. And so if you're reviewing your results of your functional assessment and your treatment recommendations, and let's say parents are concerned about one piece or another, you have to get that resolved before you submit that report to an insurance company to get approval for treatment. We added a line right to our report where the parents can sign off. So that was different. Sometimes when we submit our reports, the insurance companies have more questions before that they'll make an approval, and so they often request a physician-to-physician call. And I was really nervous about making my first call, but it was really helpful. So you're not always speaking directly to a behavior analyst, but you're speaking to somebody who usually knows about autism, and because you're not speaking to a behavior analyst, you have to be able to describe what you're doing to somebody else who doesn't speak the same language, so be able to describe your terms and all of that, and why it's important that you're providing the service and how long you think it's going to take and that sort of thing. You're going to clarify what's in the report. Sometimes that's all it takes. They have a question about something in your report, you clarify that, and you're done, you're good to go. They also often want to know, has a different intervention been tried before? Have they tried something that's less intensive than what you're recommending? So you need to be able to get that information from the family, include that in your report, and then be able to talk about that. Yes, they've tried this other intervention and it wasn't very effective, or it was effective, just not, it didn't get the child the behavior where we need it to be. They often want to know if a medical concern has been ruled out. So for example, if we're working on toileting, they want to know if there's any medical concern there. Has that been ruled out? That's important for us too as providers. We want to make sure that that's been completed. Are the concerns that we're addressing developmental in nature? They often want to know that. What risks are associated with treating this behavior or not treating the behavior? And then sometimes you have to clarify whether you're asking for units or visits. So really be careful that you get that. We had to go back and forth, I think, 2 or 3 times with one payer because we were asking for visits or units or vice versa, and we got mixed up in the document a couple of times. So we had to get that nailed down before we could see the client. So those are the primary things that we often get asked about when there's clarification for our recommendations before it gets approved. Let's see. And then once you submit it, of course, sometimes it takes the company a little while to review your plan. Some payers turn it around very fast. I think we have one payer that can review our treatment plans in a couple of days, which is wonderful, which allows us to schedule visits very quickly. Other folks take, a longer period of time, so you need to plan for that too. And once you've submitted a number of requests for treatment, you kind of get to know which payers take longer, and you can plan accordingly. Monica keeps track of all of that. For service denials and appeals, so far, most of our denials are happening on the front end. So maybe after we complete an assessment, but before we provide treatment, rather than after the service has been pre-authorized and rendered, which is good for us. It sounds like that's not the case for some other folks here in the audience. That's good because then we've been able to have those conversations, get some things clarified, and then be able to get the treatment authorized. Or we've gone through an appeals process and we're able to eventually be able to provide those services. If it goes to appeals, it's very time consuming, but it's worth it because remember, as new as we are as providers to this game, the insurance companies are also new to covering ABA services. And so there's a learning curve for all of us. And so by going through the appeals process, it helps in that education process on both ends. So we have been most successful with appeals when the family was actively involved. And so they're providing in addition to whatever documentation we provide, they provide information about the history of this behavior and how it's affecting their family. Sometimes they'll write a letter or something like that. It's been very helpful to have the family involved. So we work really closely with them during the appeals process. Let's see. In some cases, we also provide additional information about the law so that it's clear. So, for example, sometimes we're asked, this is this behavior, obviously it's a concern, but it's not a risk to the child. So maybe they're not engaging in any aggression or self-injury. And so we provide clarification that, that's not always necessary for this ABA service to be covered. And you, as a provider, you should know the law backwards and forwards, because you need to be able to either know what you're practicing, and also you have to educate other providers too. We're a network of providers, so we need to work with each other and be able to share that knowledge. And in terms of making sure that things don't get denied and that you get paid on time, complete everything in a timely fashion. So one of the things that I've learned from the university physicians is that, however, if it takes a long time for your form to get from your provider to your billing agent, the longer that takes, the less likely you are to get paid. And so the longer it takes for the claim to get from your billing agent to submission, however long that takes, the longer it takes, the less likely you are to get paid. So be fast about it and try to do what you can to be efficient.
Can I interject here?
Yes.
Contractually, you have a requirement to submit the forms in a certain length of
Right.
time. And if you do not do that, then it's an automatic denial, which you did not submit your claim timely. There are factors that can, for reconsideration purposes, if, maybe your billing person was out, sick leave and, something happened, but try to get them in as soon as possible. And the normal standard is 90 days for most provider contracts. There are Missouri laws, Angie can speak to, and they're a little more lenient, but the contractual standard is 90 days, so do it a lot faster.
For service documentation, this would be like your progress notes, your clinical notes, that sort of thing. Not much has changed here in terms of content. Different payers require different things, and so we've created a template based on the payer who required us to go through that audit process. So just some things that we include in our progress notes, the codes that we build, the duration, and we also include our license number. Even if, like, we have our electronic medical record, and so it has our credentials, but then in the body of the clinical note, we still go ahead and include our license number just to be on the safe side. Monitoring collections, university physicians takes care of this, and there's not a whole lot to monitor right now, but some of the information that they provide include, again, what are the denials, information about the billing process, how long is it taking to get from point A to point B to point C, and they can give us that information according to our whole agency. They can give us that information based on the different services, and they can also break it out by provider. So at some point, if you wanted to use that information to track billable hours for a provider, for example, you could do that. So it's a lot of information. I think it's going to be helpful as our volume increases. Yeah. I'm gonna go.
Brenda,
I'm sorry, Brenda, did you?
No, it's okay. I think, so in talking about the value-added services for your billing agency, when you're interviewing or hiring an agency to represent you and do the claims filing and the billing for you, there's a lot of services that you might be able to ask them about. And in addition to billing the claims for you and having that expertise, they're going to be able to hopefully provide you the level of detail that you need to manage your practice on the claims, getting paid, that sort of thing. But also they can, as in the services that Monica and I work together on, help you reach your provider relations at the insurance plans. They may have contacts at the insurance company level. Just some additional value-added things that they can do for you, so you're not out there just as a lone provider trying to navigate that world. So if you're going to have a billing agency, you might seek out someone who's familiar with your services, and then those additional things they might be able to do for you.
just one other thing about billing agencies. Typically, they charge a percentage of what your collections are. It varies a lot, so buyer beware. It can be negotiated. Just a few things that we've learned over time. And they may be stating the obvious to you, but just in case you haven't been involved with this before. Okay, so successes. We feel like this has been a real learning process, as you've heard us say many times, and that alone has been a success. We've learned how to work with people, to advocate for families. We've improved our own processes. Those things aren't quite up there. We did begin billing in June, as noted here. More families have access to ABA services at our facility now because of this. So it's the tip of the iceberg. We have a long way to go, but truly it's made a difference. And then we don't, of course, it's sort of taboo to be sharing rates per se across agencies. You don't want to get into a situation where you're accused of price fixing or any of those kinds of things. But it's clearly our impression that the rates from private insurers are higher than most public agencies. Of course, you have more overhead. On the other hand, there's a benefit to working with private insurers. There are probably other successes, but in the interest of time, let me just talk a bit about challenges. Startup costs. The startup costs are primarily in time. Time is money. But as you're going into this, be patient with yourselves and allow some time for this. It'll have a positive outcome. Don't get discouraged. But the policies and procedures documentation we talked about, that one audit, it was actually very beneficial to us to organize. We thought we were well organized. We just didn't have our documentation for our policies and procedures as well as we do now. There are some ongoing costs that were unanticipated. We now hire all of our implementers. Previously, we had systems where we shared costs. Families made arrangements with groups like Senate Bill 40 boards, sometimes paid out of pocket. This is probably the biggest unanticipated expense that we've had, both in time and in money. There's the upfront hiring costs, there's the training costs, there's turnover. Implementers are certainly not in it for career advancement, although many of them are in it for important reasons, but there's a lot of turnover. And then there's other overhead costs. There's some increase in documentation. I think as we get used to this, it'll go faster. The pre-authorization process, even agencies like Senate Bill 40 agencies have pre-authorization processes. They're different, so you have to learn a new set of pre-authorization processes. The denial process is different. I mean, again, hopefully that doesn't happen too often, but it's a cost. And then in terms of challenges, at our facility, we frequently have the question come up, what is the impact of the legislation on other providers? So, for example, is there an impact on the collections of our psychologists for treatment? Is there an impact on our speech-language pathologists who struggle? I'm sure many of you are familiar with the difficulties speech-language pathologists and occupational therapists have billing insurance these days. Many practices have shut down because of it. We don't know whether this will, we do have speech-language pathologists who are billing for kids with autism now. They were before, but we're hoping that we'll see stronger collections so that and fewer denials, frankly, for these kids so they can access the services they need. And then finally, we don't really understand the impact on families. You know, we all went into this thinking, oh, this is going to be so much better for families. And then the families that are struggling with $40 copays for every time a line therapist comes to their home, and they come many times a week, we think that problem, that's not the norm, by the way, but there are occasions when this has happened. And it's because there's some breakdown, we believe, in communication at the employer payer interface. It's not the payers. Payers can talk more about this. It's the employer that sets the that policy. But there's still some things that really need to be. One of our families has a higher charge for their in-home ABA therapy services than they've ever had before because of the copay. Mm-hmm.
United Healthcare Foundation is one of the companies, organizations, I should say, for United Health Group, and they do have grant funding for, you have to be fully insured, you have to write up your grant proposal, and they're not astronomical dollars, but they are very helpful dollars. It has to be quota coverage benefit that you would actually be paid for, and you could submit those through United Healthcare Foundation, I believe, is how it's out there. So we have done a lot of that. There's Make-A-Wish Foundation also that we are a partner with. So there are grant programs that are able to assist those families who need some financial assistance.
Thank you, Judy. That's very helpful information. We also, yeah. The families, right. We also know that in our county, our Senate Bill 40 board is attempting to understand all of these things and determine whether private insurance is the payer that comes first. But then if families have residual costs, we're still in the process of understanding, can our Boone County Family Resources is our Senate Bill 40 payer in our state, can they help? What's the role of the regional offices with these copays that families might have? So there's still much to be learned, but be aware that some of your families may need assistance with getting through these things because we're all surprised by them. And so,
I just
yeah,
have
one other comment.
I have one other comment. I don't remember when it came up, but there was a question about why aren't we getting more families calling about using their insurance to cover these services. And I don't have all the answers, but I know that there's a lot of confusion with both families that we see and with our payers about what is ABA. And so a lot of people still think that ABA equals early intensive behavioral intervention, or it's only for problem behavior reduction, and there's a whole slew of other things that we do. So that's been tricky. So when we get families or we get a referral for services or something like that, and we contact a family, they're not always aware that they can use their insurance to cover ABA to treat other things, or like for toileting or to address daily living skills or something like that. And so that's been very, very tricky. And so as a provider, it's our responsibility to educate, what is ABA, what does that encompass, what can we do with that? And then there was also a question about a licensed assistant behavior analyst. And why some insurance companies recognize that as a higher credential and why some of them recognize them as line therapists or paraprofessionals. I think that's a challenge at the national level, actually. What exactly can a BC ABA do, or a licensed assistant behavior analyst? And I think we need to clarify that a little bit more. What can they do independently? What do they need supervision for? So that absolutely needs to happen at the national level and at the state level as well. And I think when that confusion is cleared up, that should help with some of our billing issues with licensed assistant behavior analysts.
And let me put in a plug for Angela's resources here, because again, we have referred some families who were in a quandary and it didn't make any sense to us. They tried a lot of things. They went to Angela's division and were able to get support and help for that too. So, and sooner rather than later is probably something that we've learned. Don't wait to have families call. I'm sure, Angela, when you talk, you'll be giving the contact information.